Hello and welcome. My name is Timothy J. Miller, and this is episode 5.2 of the Chronic Pain Survival Guide podcast. Part 1, Introduction. Okay, so I missed my release date for this episode because I had to re-record it. There have been some exciting developments recently that I will discuss momentarily. During episode 5.1, we discussed the CDC's contention that the 2016 Guideline for Prescribing Opioids for Chronic Pain was simply recommendations for primary care doctors that were being misused. Even if that was the case, which it's not, a 2011 Henry Ford Hospital study from 8 years ago found that chronic pain specialists are outnumbered by patients in need of help nearly 30,000 to 1. The disparity is surely much worse now in the wake of the 2016 Guideline. Let's pretend the CDC Guideline was for primary care doctors only. The reality of the situation is that most pain management falls in the lap of primary care doctors. The Henry Ford study illustrates that clearly. That may be part of the reason patients like myself have found it so difficult to find pain management, or even a primary care doctor in recent years. Chronic pain has placed us in a category of patients that are seen as personal and professional liabilities. We are feared, rejected, and shoved out into the cold. In episode 5.1, we discussed the fact that Congress mandated the VA follow CDC guidelines by law, and the guideline also springboarded legislation in 60% of the states in the U.S. These recommendations are law for the majority of Americans, no matter what the CDC says. In episode 5.2, we talk about the minds behind the 2016 Guideline. We have an opioid overdose crisis in America. There is no denying that. The illegal drug market has been poisoned. Heroin and illicit fentanyl are flooding our streets, and law enforcement, especially the DEA, continue to be embarrassed by the black markets and murderous cartels. There is not a prescription opioid overdose crisis in America. That is why slashing opioid production, as discussed last episode, and a huge decline in the prescribing of opioids by physicians has done nothing. The number of overdoses is surging, as a matter of fact. Nevertheless, the CDC Guideline for Prescribing Opioids for Chronic Pain and subsequent 2019 media release are not about managing chronic pain at all. Instead, the focus is still on tapering patients off of opioids. Even self-proclaimed supporters of the 2016 Guideline admit that the evidence base behind the CDC's recommendations is weak. So who was behind the Guideline? What was their agenda, if any? Why is the Guideline's only focus on the reduction of opioid prescribing instead of a successful approach to pain management? A lot of that has to do with the people behind the Guideline, and that is what we're going to talk about today. Before we get started, there's something exciting to discuss. After the conclusion of episode 5, the Chronic Pain Survival Guide podcast is going to take a short break. Moving forward, I'm going to start releasing this podcast in seasons. Each season will have 10 episodes that will be recorded, sound engineered, and ready for release prior to the first episode being released. That way, all episodes will be released once a week on the same day of the week for 10 weeks in a row. No more delays in release dates. I'm also starting a break-off podcast that will be called Liberty Lost. The Chronic Pain Survival Guide's focus will narrow and cover stories of chronic pain patients and pain-related news only. The focus of Liberty Lost will be the growing loss of liberty in America. Season 1 will focus on the attack on the medical community over opioids. And I already have commitments from some of the top doctors in America for interviews. Make sure to tune in to Liberty Lost, because as the seasons progress, I will cover more than just chronic pain-related issues. It will truly be a podcast that all Americans will find relevant. With that said, a lot of the content of Liberty Lost will be about chronic pain, because that is one of the areas we are getting hit the hardest. Before we start looking into the experts behind the 2016 Guideline, I have a few favors to ask of listeners. If you or someone you care about lives in chronic pain and their story needs to be told, reach out to us at wecanbeatpain@gmail.com. Again, that's wecanbeatpain@gmail.com. Also, please rate and review this podcast on your listening app of choice and on social media. Lastly, a transcript of every episode of the Chronic Pain Survival Guide podcast including links to all sources of information used to create the episode, can be found on patreon.com. That's patreon.com/chronic pain. All right, let's get started. Part 2, the experts. After digging into the acknowledgement section of the 2016 guideline, it was clear. The number of substance abuse professionals who were consulted outnumbered chronic pain specialists substantially. Those consulted were called the Core Expert Group. The Core Expert Group facilitator is a man by the name of Dr. Don Teeter. Let's look into Dr. Teeter. According to the About page on Dr. Teeter's website, Don Teeter is a family physician who has lived and worked in Western North Carolina since 1988. His work in the Southern Appalachian Mountains made him aware of the problems with opioid pain medications years ago. In 2004, he started a clinic to treat those addicted to opioids in his primary care practice. From 2013 to mid-2016, he worked as medical advisor at the National Safety Council, addressing the national epidemic of opioid abuse, addiction, and overdose. Dr. Teeter was the lead facilitator for the expert panel discussion during the development of the CDC Guideline for Prescribing Opioids for Chronic Pain, United States, 2016. Since June 2016, Teeter has worked for Teeter Health Solutions to concentrate on educating prescribers and others on the science of opioids and how that should influence treatment and policy decisions. Currently, he contracts with the Centers for Disease Control on the academic detailing of prescribers to educate them on the appropriate use of opioids for the treatment of pain. He continues to work 1 day per week, treating those affected by the disease of addiction at Meridian Behavioral Health Services in Western North Carolina. Okay, so the CDC Guideline was supposed to be specifically for prescribing opioids for chronic pain. Nevertheless, a cursory look at the core experts reveals that substance abuse experts outnumbered pain management specialists by more than 4-1. This is not surprising at all, considering the core expert group facilitators' focus was not chronic pain, but instead addiction. Another group that played a major role in the 2016 guideline is the Physicians for Responsible Opioid Prescribing, PROP. Dr. Andrew Kolodny, a psychiatrist, is the co-founder and the executive director of PROP. Let's hear what Kolodny told the Washington Post in regards to the FDA's recently renewed interest in the efficacy of long-term opioid use for chronic pain. On February 25, 2019, Larry Bernstein and Laura McGinley wrote, "A finding of ineffectiveness in more rigorous studies supervised by the FDA could allow the agency to change the labeling on some opioids, impose special rules for prescribing, dispensing, and taking them, and even prohibit their use in some cases," according to FDA Commissioner Scott Gottlieb. Quote, "We are going to impose a mandate on existing products to answer the question that people have been posing for years, whether you have declining efficacy and whether that declining efficacy can lead to addiction," Gottlieb said in an interview. But at least one longtime critic of the FDA's response to the opioid crisis expressed frustration with the move. Andrew Kolodny, director of Physicians for Responsible Opioid Prescribing, said the FDA already has all the research it needs and authority under existing law to tighten restrictions on the use of opioids for chronic pain by changing instructions for how they should be prescribed. Quote, "Here we go again," Kolodny said in an interview. "That's exactly what the FDA said to us in 2013. 5 years later, we don't have the studies and another FDA commissioner says we're going to do the studies." Man, Kolodny is such a puke. So which one is it? The FDA has all the information they need, especially because Kolodny said so? Or the necessary studies need to be completed? What has changed in the last 5 to 6 years is the DEA's mandated aggregate production quotas, APQs, for opioid pain medications. For example, over 1 year before the CDC's 2016 guideline, the APQ for hydrocodone was 99,625,000 units. This was in 2015. 4 years later, the 2019 APQ for hydrocodone was 43,027,640 units. That's a 56% reduction in hydrocodone manufacturing, and it's mandated by the DEA. During the same 4-year period, Codeine manufacturing was cut by 43.5%, morphine by 53%, oxycodone by 43%, and fentanyl manufacturing was reduced by 48.5%, but I guess that one doesn't really matter since the cartels are now supplying it. Kolodny and Prop are clearly getting what they wanted, and it comes at the expense of chronic pain patients like you and I. There are countless reports of needless patient suffering by both doctors and patients. That is, unless you ask Kolodny. According to the Pain News Network, on May 22, 2019, a noted critic of opioid prescribing calls reports like these exaggerations. Andrew Kolodny, MD, the executive director and founder of Physicians for Responsible Opioid Prescribing, PROP, told Statline that the number of doctors who are inappropriately tapering patients is likely very small and should not be blamed on the CDC. Quote, "We have a very real problem in this country, but the CDC guidelines didn't cause it," Kolodny said. "The problem is that millions of Americans have been put on round-the-clock opioids at very high doses, and for reasons that doctors now realize were not appropriate." His quote continues, "What the FDA needs to tell doctors is that because it is so excruciating to come off of opioids, they need to be very selective about who they put them on." In a series of tweets 2 years ago, Kolodny said patients on high doses should be forcibly tapered, even if the patient refuses, and challenged assertions that forced tapering was risky and widespread. Now Kolodny says he sympathizes with patients, but claims they are being manipulated. Quote, "Their emotions are real, but they're being effectively manipulated to controversialize the CDC guidelines," he told Statline. Well, there you have it. The executive director of PROP, a group who deeply influenced the CDC Guideline, explained to us what is really going on. Forced tapering is not causing a widespread crisis, and the anecdotal stories of people suffering are both exaggerated and manipulated. Let's return to the May 22nd Pain News Network piece to hear some of these reports that Kolodny claims are exaggerated and manipulated. Quote, "I have been forced to taper to 90 morphine milligram equivalents, MME. I had been stable and functional for 10 years at 135 MME. Now I can no longer work and can barely take care of my children. I'm considering suicide because my pain is unbearable." Another patient reported, quote, "I live in constant anxiety that I will be abandoned, which worsens my pain. Refused any pain management, or reduced to a dose so low that taking my own life is the only way to escape the pain." A third patient claimed, "My forced taper was a little over a year ago. Before that, I lived a small but functional life on high-dose opioids. I took the same dose from the same doctor for over a decade. Then I was forced off 75% of my dose. Once we got down to my current dose, the medication was no longer enough to control my pain. I now live a tiny, non-functional life. I spend all of my time in bed watching TV. I never leave the house. Showers are my worst enemy, and I am lucky I wasn't abandoned by my doctor." Kolodny completely discounts statements like this. In addition to being the co-founder and executive director of PROP, Kolodny is one of the biggest promoters of Suboxone out there. He is also the chief medical officer for the largest chain of nonprofit detox and rehabilitation facilities in the U.S. Ever heard of Phoenix House? Since the early aughts, Kolodny has been a staunch critic of drugs such as Oxycontin and oxycodone. He often cites the legal trouble that Purdue Pharma got into over claims that the drugs have a low risk for abuse and diversion. But guess what? Kolodny has made the same exact claims about his pet drugs, Suboxone and buprenorphine. He claims there's a low risk for abuse or diversion. He has been a personal hype man, like a Flava Flav of sorts, for the thebaine-based synthetic opioid. It was almost like he was personally vested in the drug's success, and we will get to that in a petition I discuss at the end of this segment. Kolodny aggressively marketed Suboxone to prisons, public hospitals, rehabilitations like Phoenix House, and more. In a 2017 documentary for Kentucky Educational Television, Kolodny claimed opioids should only be used for post-surgical pain and for a few days only. He also claimed that what chronic pain patients needed instead of access to pain medication was more funding for medication-assisted